spend, excuse me, we'll spend a lot of the first half of our session talking about the screening and triage workflow with nurses, as well as managing requisitions. And then we'll spend the second half talking about the scheduling book design. Some housekeeping notes: please mute when you're not speaking. Please state your name when speaking to support the meeting notes and any follow-up items that we might have. And for any non-urgent questions, please put them in the chat.
And also, we've started recording, just so everyone's aware. We record the session for our own note-taking.
Thank you. Okay, so introductions. I think we all know each other. Excuse me.
This is my first time being on a call with Shannon. So I'm Kat, and you might see me sometimes in the system as Catherine, but you could just call me Kat. And I'm the informatics manager with ACU in my portfolio. And Mark is the informatics specialist, one of which who is in the medical daycare portfolio as well. But Mark's also an amazing specialist at transfusion medicine.
Hey, nice to meet you both. I'm Shannon. There's someone else on the call that I don't know. But I'm Shannon. I'm the new PCC CAD for the outpatient clinic, so including oncology and ambulatory care. So it's nice to be here.
Awesome. It's nice to meet you.
Okay, so again, the purpose of our session is to go over the operational and clerical workflows. We'll function in Cerner. We'll acquire decisions about some of the key workflows involving scheduling and screening and triage. And we'll explain some of the decisions required for any clerical build. So handing it over to you, Kat, to go over some general scheduling overview.
Oh, I think you're looking at an older version of the deck, Mark, because I moved these slides to later. Did you download a copy?
I did, yeah.
Okay.
Okay, let me share what we have in OneDrive.
Just go ahead and skip to your section that starts with the nurse screening and triage.
Okay.
Yeah.
Perfect.
Yeah.
All right. So we'll start with this one, which is the nursing screening and triage workflows. So in our previous sessions, we learned that the nurses play a role in screening and triaging appointment requests to the ACU. So some of the clinics across the region follow similar practices, but we really don't have a standardized workflow in place. So to address that, we've outlined some options for you to choose from based on what aligns best with your needs and your workflows. So we'll come back to this diagram later, but I wanted to show it to you now just to help frame your thinking a little bit. So in the future state, there will be two main ways that you'll get appointment requests. The first pathway would be through faxed paper referrals, which is here at the top. And the second pathway is through entering scheduling orders in Cerner. So for now, let's focus on the second pathway here while I go over the different options for how the nurses can screen and triage those scheduling requests. Okay, so I split the different options into two overarching workflows here. So it's either the nurse screens the orders after the appointments are booked or before the appointments are booked. So I'm going to go over each of the options here. The first one is to utilize the ambulatory organizer to screen the orders. So the nurse can check upcoming confirmed appointments in the AM organizer to make sure the orders are complete and they're appropriate. And this is what most clinics do since it works well with existing tasks. So for example, nurses will have to transcribe conditional orders and administer orders before transfusion appointments. So it makes sense to do the screening at the same time. Now, if there are any orders or appointments that aren't correct or that need to be canceled, then the nurse can let the clerk know through various means. And this is totally up to you. You can use AMP Organizer to leave a comment. You can use Message Center, which is kind of like email in PowerChart, or you can just talk to the clerk and let them know that, hey, this appointment can be canceled. Second option is to use the confirmed appointment slate report to screen orders. We can set it up to auto print as often as you'd like. And then once it's printed, the nurse can just go through it and then just mark any appointments that need to be canceled. So both option 1 and 2 are kind of the same, except option 1, you're looking at an electronic slate. So you can jump to the patient chart just by clicking the patient's name. With option 2, you'll have to type and search the patient's MRN and power chart. Okay, so for option 3, the nurse would have to use scheduling appointment book to check the clinic's appointment request queue. So for any appointments that they approve, the nurse can move that appointment to a different request queue that's specifically used by the clerk to book appointments. Fourth option is the same thing. The nurse would have to use the scheduling appointment book to look at the queue, but instead of moving one appointment to another queue, the nurse can just leave a comment on the patient's chart, and the clerk will book accordingly. So an example would be if there are IVIG appointment requests for a patient up to July, but they're only approved for until March, the nurse can leave a comment saying IVIG approved until March 2025 or something to that effect. Then our last option here, which is our recommended option, is to use the scheduling request by order date report to screen appointment requests within specific time ranges. So for example, we can pull this report to pull appointment requests entered yesterday or last week. The nurse would then mark on that report which appointments can be booked, and then they'll hand it to the clerk to follow. So here's a screenshot of the report, and as you can see, it includes patient information and details of the appointment request as well. Okay. So before I move on to WorkQ Monitor config, do you have any questions? Yeah, go ahead, Kim.
You can only do this one, Mark, by printing it off every day. This one is not on a screen.
No, that's right. Yeah.
And we can configure it to auto print. So you won't, no one will have to generate the print. We can just say every day at 7 a.m. print all the orders that were entered yesterday.
Okay, then that sounds pretty good to me. And this is what Seasheld has done?
Seasheld is not doing a robust screening process. I have been working with them over the last year to start screening by their booked appointments. So they're doing basically option 1, I think. Seasheld has a slightly different problem because they don't accept faxed requests as well as electronic ones. You are still going to be accepting faxed requests for your nurse task appointments like wound care and bladder scan and things like that. So we tried to come up with something that will work for both of your workflows together. So I'll let Mark go ahead to talk about what we recommend for your faxed requests.
Okay, I think next for WorkQ Monitor config.
Yeah, I updated this slide just a little bit also, Mark, so maybe it's a good time for you to go and pull the live copy of the presentation while I re-explain WorkQ Monitor. So after Cerner Go Live, typically we change your fax number to a WorkQ Monitor, which is to say that you don't get paper faxes anymore. Your documents just come straight into Cerner. You don't necessarily have to do that. You can continue to use a paper fax, but then some of your documents you will eventually have to get into Cerner somehow. And so what I try to do when I'm making a recommendation for you is I make a list of all the documents, paper documents I think you're going to be dealing with after Go Live. And some of them are going to be faxed to you by ordering providers. Some of them will be completed by you in clinic on clinic day. And if a clinic has a huge majority of things that are faxed to them by providers, then WorkQ Monitor is a great idea because almost everything you're going to get faxed to you, you're going to want to put in the chart. Go ahead, Kim.
Sorry, I think I missed a step somewhere. Why are we still receiving faxes? I thought everything had to be put into Cerner.
Because of that form, it's in the middle of that list that Mark's showing there, the qGH Healthcare Service Request Form. That form is how providers who are in their offices are going to still ask you for appointments that don't require physician's orders. So like wound care and bladder scan and those things like that.
Okay.
That's typically how we have recommended it, because those providers are going to keep using that form for other things that's on that form that they need to send the patient into the hospital to. We don't expect GPs in their offices to use Cerner to enter labs or ECGs or anything like that. So wound care is a great example where they're going to keep faxing you that form. And so when I look at all of your forms, I think you could go, like, I think that you could choose to keep receiving paper faxes and then get those fax documents into Cerner yourself. Maybe I'm explaining this badly. Let's go to the next slide, Mark. I think there's a decision point slide. Okay, so also, I'm not going to read over all this, but people usually want to know, what does HIM do after go live? They're still going to store all the documents. So no matter where they come from, no matter if you index them or not, if you end up with a paper document, they are going to store it. If you don't scan it, they will. So they also do that, but their turnaround time for scanning is very slow. So you can never send a document to HIM for urgent scanning. They're only for archival purposes. So if you have a document that you think might be needed by somebody in the next couple of days, you should not send it to them, because it could be in the bowels of HIM for 3 to 7 days. And so in those instances, you should scan the document yourself by faxing it to your work queue monitor. So an example of something where you can just send it to HIM is a transfusion record. That's fine. You don't need to see those within the next 3 days, but a blood consent, typically we would say you should scan that, because you don't know if someone's going to need to see that in the next day or two. Don't send that to HIM, because it'll be you can't access it for a week. So options for work queue monitor configuration for your clinic. Option 1 is typical for most medical daycares, but you're not typical. This is where we convert your fax number at go live to go straight into Cerner using work queue monitor. And then anything faxed to you lands in an electronic queue, and then the clerk attaches it to Cerner if needed. Option 2 is, so I'll say the problem with that is that the nurse doesn't work in work queue monitor typically. So in a workflow where you want a nurse to be able to screen and triage your requests, having everything go straight to work queue monitor makes it awkward. It means the clerk has to print from work queue monitor and put it in front of the nurse, or it means the nurse has to learn to use work queue monitor, which I just don't recommend. It adds workload to the nurse and it's very awkward. Option 2 is where we keep your paper fax number. So all of your faxes will still come in on paper. Clerk can sort out the ones that need to be seen by a nurse and put the papers in front of the nurse. And then after that, then you can use your own fax machine to fax documents to your work queue monitor and then attach them to the chart. So this is actually my recommended option for you, is option 2. So all your faxes will still come in on paper. You can sort them how you need. If the nurse needs to screen or triage a request, like a request for wound care, you've got a piece of paper you can put in front of the nurse. And then after that time, that and anything else that needs to be indexed, like a blood consent, the clerk can fax to work queue monitor. So that's what I'm recommending. The other option is what we've done for some other clinics, where we change your original fax number to work queue monitor, and then we get you a new fax number, but I don't think I won't go into that option anyway. Mark, do you want to go ahead to the next slide?
Yeah, so having gone through all the options, this is our proposed future state workflow with both Kat and I's recommendations for both pathways. So for fax paper referrals, our recommended workflow is this one. So the provider will fax those referrals to your clinic. The nurse will screen the referrals. If they're approved, then the nurse will scan it to work queue monitor. The clerk will then look at work queue monitor. They'll see which referrals are there, and then they'll go ahead and book that. And then after that, they'll index the referral to the patient's chart. Now for those scheduling, for those appointment requests entered in Cerner, you'll get this report here, auto printing in your clinic. with whatever frequency you prefer. The nurse will screen the orders in PowerChart using that report. The nurse then will indicate on the report whether the appointment is approved or if it needs provider follow-up whatsoever. They'll mark that on the report and they'll hand it to the clerk. The clerk will then book the appointments based on that report. Do you have any questions, thoughts, comments about that proposed workflow?
Sure, Shannon has a million questions. I'm sorry you're coming into this in the
I know.
middle.
Sorry, Shannon, you just have to kind of guess how this is going to work. It sounds really, really good to me. Carrie's been in the sessions before as well, and I think this is kind of how we envisioned it, but I won't speak for you, Carrie. What do you think?
Okay. Okay, sounds good. So we'll consider this workflow validated then.
Awesome.
Okay.
Are you okay
And
with
then
that,
no more-
Shannon?
Yes.
But
It's
so-
so to comment on something that we've never really used or
I know.
done something. So I feel like we have to do whatever you recommend at first, and then I mean, obviously we're gonna have opinions once after we use it.
I'll tell you what, something that I hope you'll find comforting, which is that this second row in the workflow here, where Mark is showing how you're going to deal with electronic orders, there's no configuration really needed for that. So if it's not working, we can change it to something else. We can change it on a very nimble basis. It's just this top part here, where we have to figure out how to sort out your work queue monitor configuration. We have to decide on now, and it's a little harder to change, not impossible. So as far as the electronic orders, which is going to be 95% of your orders, we can change how you deal with that if it's not working.
I think the biggest change in kind of like practice, besides the obvious, mechanics of it, will be we're going to have to book time, Carrie, for you to do all this triaging, right?
That's exactly what I was
So-
thinking.
I know, it's like,
Am I working
scheduled
10-hour days here? No, it
Yeah.
just feels, maybe in the beginning, it just feels like I'm fine with computers, but it just feels a little onerous. But it will get easier with time.
100%.
We definitely are gonna have to be booking time for this.
100%.
I think we can move on to the next topic here. Kat, I think this is your part.
Yep, I'll share my screen now, Mark. I'll let you off the hook. Everyone see my screen? Okay. So Shannon, here's your overview of how scheduling works in Cerner. It's a 2-slide overview, so I hope you're a fast learner. No, I'm just kidding. We'll definitely go over this with you again. As a reminder, the scheduling appointment book is the application that the clerk is going to live in all the time. Nurses might use this occasionally, but this is not where you do most of your work. So the thing I want to call your attention to here is this item number 3 here is a bookshelf. The bookshelf has a name. It's in this teal bar. And then on the bookshelf is a number of books. We're going to talk today about how to configure your bookshelf and your books. And we're also going to talk about how to configure your resources, which is this number 5. And a resource is a bookable thing. Typically, it's a chair or a bed. It can also be a human. And then slots are what are the available times or things that we book to the resource. So we're going to talk about those today. We can come back to this picture if we need. I think I'll skip that one. And just a quick overview of ambulatory organizer. This is what nurses and other clinicians see for a list of appointments. You can use it to view a list of appointments that's coming up tomorrow or 2 days from now. And you'll also use it to see what's happening in clinic today. And when you are loading ambulatory organizer, you can choose which resources to load. So what I mean by that is, if you look over here on the left-hand side, you can see this gray text that says VGH MIC Chair 1, Chair 7, Chair 8, Chair 4, etc. This view tells me that the nurse is asked to see VGH Medical Infusion Clinic chairs as a resource group. if they want, they could say, also show me the doctors or whatever, however we configure the resource group. So we'll go through that configuration today as well. So Kim saw this slide at the meeting we had last Friday because we need to configure your appointment bookshelf. So back to this image here. And the bookshelf should contain all of the books that a clerk needs to do their job on a given day. We don't want a clerk in that given workday to have to switch bookshelves. So we have proposed a bookshelf called Allied Health, which will have books in it for all of ECG, PF rehab, dietitian, SLP, diabetes. But Kim, you said you're not sure about the bookshelf for ACU oncology. So because you don't want to maybe put them both on the same bookshelf, is that right?
Well, even adding an and between the two words, I thought would be better, just to decrease, something like that.
Okay, I don't know if we're allowed a special character of an and, but I'll find out for you.
Okay. Because then you go into the shelf and ACU has a book and minor procedures has a book and oncology has a book and surveillance has a book, right? Yeah, okay.
Yeah. That's well, if we can't use the and, I might just have to put the word and in. Yeah. And then inside for the books, we are recommending definitely oncology. You've got so few resources, we'll probably easily fit them all in one book. Minor procedures obviously will just be one book. ACU, I want to talk to you a little bit more about the book design, because when the book has this many resources in it as ACU is going to have, it can get a little bit cluttered. And so we want to make some other books. So we can make you as many books as you want. We can slice and dice and repackage your resources 8 different ways if that's what works for you. We don't want to clutter your bookshelf, but you only got 3 so far. So absolutely we can add more. So for appointment books, what resources will the clerks primarily want to see on appointment day versus when they're booking? That's what the question I ask. So I'll walk through this slide with you. In this first column is all of the resources that the ACU clerk could possibly book. So when they're booking, they are going to need this book. This is called the all resources. I've added the chemo chairs in here. Oh, sorry, that should have said chair 1 through 4. Because I understand that sometimes you put infusion patients in chemo. So what we're going to do is oncology is going to own these chairs, but we're going to share them into the ACU book. So you'll be able to see and book to them. You don't own them, but you can still book to them. And then we'll have the internal medicine provider. We're not going to lay them all out by name. We're just going to have one resource, and whoever's on service, that their appointments get booked in that resource. Same as anesthesia, and chatting with them. There's no point in laying them all out individually by name because they're not going to look at their Cerner schedule anyway. So we're just going to have one anesthesia provider resource. The surgeons, we do have to list out by name because they do work off of a Cerner schedule that's attached to them personally. So we're going to have one resource for each surgeon. How many do you have again?
Well, by the time this goes live, we might be down to 2. I don't know if they've replaced the one who's retiring the 1st of April. So you've got Kathleen Garber there, and Ashley Shaw is the second one for sure. And then I don't know about number 3 yet. Maybe Carrie and Shannon have heard something. No.
Okay. And then the NSWAC nurse, I don't know if we're going to list them by name or if it's going to be generic. That's up to home health, how they're going to build the NSWAC nurse. So we could have 1 or 2 there. And then the allied health folks will be listed by name because that's how they've decided to build their book. So if you imagine all of these resources, going back. So do you see each column here is a resource? So if we list all of these resources all the time, every time we look at your clinic, it's going to be really cluttered. So I only want to list them all when needed, which is for when the clerk is booking. The other place, so that's the all resources book. We also are going to have a book that's just for ACU on clinic day. So on clinic day, we don't care about what's happening in the chemo chairs, right? Like that's oncology's responsibility. So I'm going to make another book and an ambulatory organizer group that has everything except the chemo chairs. So you can see from the nursing side or from the clerical side, what's happening today across all of our resources, but that's still a really big view. So we are recommending also a smaller view. So this third column here, that's just your chairs and beds for nursing. So this doesn't show any providers. If you wanted to see them, we'll teach you how to just add one doctor at a time. For example, if you wanted to see IM as well, but that will make your view as a nurse working in the clinic simple for just who's going to be in which chairs and beds and when. And then the last one we'll make you is just for minor procedures. So it will just be beds 1 and 2 and the surgeons. Does that sound okay?
Yep.
Okay. Awesome. So we'll call that validated. The next thing we get to is slot design. So what I mean by slot, sorry, I'm going to skip ahead. The slot is in the resource. What are the blocks of time that we want to encourage booking to? And are there specific things we want to encourage booking in that slot? And there's a couple of ways that we encourage booking of certain types of things in certain slots, and I'll go over those with you because you get to pick. So this was my translation of your booking guideline. This is not Cerner config. This is just me reading through your clerical manual and laying it out in a table format. And the way that we can add some of your booking guidelines into Cerner, we have 3 choices. We can do generic open slots, and we can name them a certain way, but it's basically just from 7:30 to 14:30, there's a slot. And if a clerk tries to book at 1500, there's no slot, they'll have to override. If a clerk tries to book at 0630, there's no slot, they'll have to override. And they're only allowed to put 1 person in each chair or bed, so basically in each slot at a time. And if they try to double book, they'll have to override. That's as generic as it gets. And this is how C-Shelp has configured their chair and bed slots, just generic. As soon as the clinic opens, there's a slot, it's the same slot all day. And then when the clinic closes, the slot is over. So that's the first option.
Sorry, can you go back to that slide, Kat? Because
Yeah.
you've got, like on the Monday, you have minor procedure, and on the Wednesday, you have surgeons, but that's the same thing.
Oh, yeah, sorry, I should have.
Okay.
I thought, okay, so when Mark and I are collaborating on the same slide deck, sometimes our changes aren't saved, and I definitely did change that, but it didn't save. So yeah,
Okay.
sorry.
Okay.
Sloppy.
And then a question for Carrie. I mean, yeah, like then you don't have the chairs open till 10 o'clock on the Monday, say.
Yeah,
But
I was gonna say
potentially
that
we
same
could.
thing. Most likely, we usually have, if not all the time, but sometimes we have an infusion in the middle of that surgical clinic for me.
So you sometimes have an infusion in chairs 3, 4, or 5 in the middle of that surgical clinic.
Yeah.
Okay, good to know. So
Yeah,
Mark,
and also, I'm just noticing that you have until 14:30, and sometimes we have Stephen working till 3:30.
So that would just
And
be a
so-
manual
Is that
override
okay?
then, right?
yeah, you can
Yeah.
book outside the slot. It's just an override. Yeah,
Okay.
so, but it's about, if you don't want the clerk to have to override, we can build the slots until 3:30, and then you just tell the clerk, don't do this unless Stephen's working, or whatever. You know, it's your choice.
I think it's
How-
easier to
if-
override when he's working there.
Okay.
Agreed.
So this, I also scraped this out of your booking orientation. I'm not going to go over this right now. I just wanted everything to be in the slide deck, so it's comprehensive, because I'm going to send it to you afterwards. So if we do generic slots, this is approximately what it would look like. You've just told me that you would also like slots in chairs 3, 4, and 5 on Monday and Wednesday from 7:30 to 10. I can do that as well. We can actually make them separate slots and name them like, don't do this unless you get permission slot, or, you know,
That's fine.
it's actually minor procedures time slot. Are you sure you want to book this? Like we can
No,
call
that's
them.
good. Yeah, it's like a second thought.
exactly. So this name that you see here, SSH ACU chair, we get to configure that name. So we can say overflow only SSH ACU or something like that. The option 2 is to do a more complex slot design. And when we do complex slot design, we have to make it look obvious to the clerk what they're supposed to book where. So this is an image of the book for VGH hematology, daycare, and apheresis unit. So they're doing apheresis, they're doing chemo, they're doing transfusions and irons and all kinds of things. And so what they've done is they've named the slots suggestive of what should go here. So you can see they expect bone marrows here, they expect irons here, a new patient teach here, and an apheresis or plex here. And you can also see the slots have a length so this one is from 9 o'clock till 10:30. So if a clerk tries to book something from 10 o'clock flowing over into the next slot, they'll have to override. So this slot has a start and an end. And if you try to book an appointment that goes over the end of the slot, you'll have to override. What they have not done is they haven't done configuration that matches the bone marrow appointment type to this slot. That is the third option, is to say only bone marrow appointments can be booked in this slot. And if the clerk tries to book a different appointment, they'll have to override. So option 2 is just visual and so basically what you're seeing here. And option 3 is to also attach appointment types that you want booked in that slot. Go ahead, Kim.
So I was just going to say, can we do a hybrid? But I think you pretty much answered that, because we do have some set ones like the CT pre-post hydrations and the bone marrows and things like that. I love the color coordination of this, but other than those few set things, the slate's pretty dynamic. So I don't think we want to block it that way. Do you guys agree?
Yeah, and you can also do lunch breaks too, but as I mentioned, if you tried to book an appointment in this slot that ran through this lunch break, the clerk would have to override. And the lunch breaks, you can't just move them. They're kind of permanent in your schedule. So, so what I would do for your complex slot design is your bone marrow biopsy slot, your pre and post CT slots, your pre and post, like basically you clarify this with me, but this is what I grabbed. You also had a 45-minute break you wanted on Stat Fridays. I don't know if you want a slot for that. Go ahead, Shannon.
I just have a question about the last slide where you said that they would have to override over the breaks. Like we constantly have patients that are there throughout the break because they'll start their infusion in the morning and then it will run through the break, but there's always a second nurse there.
So are you saying that you're not going to put the breaks in our schedule then?
I don't think so because of the way you work, unless you want them on the weekends to make sure that nobody books at a certain time. But if the break is dynamic, if the break just has to be put in there somewhere between two patients, then I would not make a slot for it.
I'm afraid that they won't happen if we don't block them in. We can always change them, right? Like you can override it.
Yes, you can definitely override. Yeah.
And Carrie doesn't know this yet, but we actually have to look at how we're doing our breaks anyway. So it's timely.
So you thinking maybe breaks on all days, Kim, or just on the weekends when you're?
No, all days, because otherwise it doesn't happen. The staff won't get their breaks at all, right? It'll just get blocked up. So yeah, so I think we should block them all the time with the understanding that there has to be a certain amount of flexibility, and we have the ability to override it and move it by half an hour, whatever we have to do for whatever reason.
So you can override and book into the lunch, but you won't be able to move the lunch slot as easily. It's possible, but generally what I would recommend is that, yeah, if you have to, you just override it, and then but we can go through that with you. So what I'm going to do is I'm going to email this slide deck to you with this complex slot design slide, and you can send it back to me. And when you send it back to me, we're going to also talk about how you want the slot named. And it doesn't have to match with the appointment type exactly. It can just be however you want to remind the clerks of what should be in that slot. And so like I said, Carrie, for your minor procedures, chairs 3, 4, and 5, you can name that overflow only or requires approval, or I don't know, we can work on that. Okay, and then go ahead, Tara.
So just to speak a little bit further to that, and sorry, I'm totally the one stepping in here, knowing not a lot of what's going on historically. But the way that it works in the schedule for the nurses taking breaks is more than anything from the clerical side, it's a visual cue, not to have any starts double booked, if you know what I'm saying, right? Because when we're looking through the schedule, we'll see 2 things starting at the same time because there's 2 nurses, right? So seeing a lunch break, we know that we can still book 1 thing on top of that, just not 2.
Lunch breaks are a little tricky where you have resources representing chairs and beds and not nurses, which is what I'm showing you here. The clinic had to work, you have to do a lot of critical thinking to figure out how many nurse lunch breaks to put in a clinic with five chairs and beds. And then how many nurses do I have? 3. Okay, so then I have to put 3 lunch breaks in every day. And then which chair and bed am I going to put those in? So I'll let you, if you take a moment and think about it, putting the lunch breaks in as slots is, it's a good visual reminder to the clerk that we need to have 3 lunch breaks today because we have 3 nurses. We've got 5 chairs. But they might have to override. I'm sorry, Tara, I know that doesn't answer your question, but it's not a perfect solution, but it is a good visual reminder.
But it's up to them to kind of determine, and it just takes time.
So as far as the other clinicians, we have to build slots for them as well, because they're also going to be resources. And my recommendation for all of the other clinicians except internal medicine is just to have generic slots. And the reason why, so with the surgeons, this is surgeons outside of minor procedures. So this is surgeons just in ACU, Kim, because they said they sometimes do follow-ups. So they will be in ACU sometimes. My recommendation is to just build generic slots because those clinicians are always going to be consulted or tell you when they want to come in. And so we don't really have any reason to build fussy slots for them. I think that's true for the allied health folks as well. Like you wouldn't book allied to come into ACU without checking with them first to see if they can come. Is that right?
Yeah, that's totally correct.
Okay, and same for NSWAC. So I'm just going to recommend slots for those folks. It's just 7:30 to 2:30, or you tell me the times of day, but we'll build those Monday to Friday for all of those clinicians. Anesthesia, would they ever do a blood patch on the weekend?
Actually, can I make one other note? You might want to build the surgeon generic slots 7 days a week, actually, because sometimes we'll have a locum surgeon that does want to do a follow-up when we're open on the weekends.
Okay. So we'll build that's my spot here. So we'll build the surgeons 7 days a week. Okay. Anesthesia 7 days a week. Allied is Monday to Friday.
Do they do blood patches on the weekend? I don't think I've ever had a blood patch done on a weekend.
No, but it's not, I can't say never,
Yeah,
but
fair.
I wouldn't say not that I've heard, but
And in my whole year and a half here, no.
No, well
And
then we'll just do
I
Monday to
can do
Friday
it.
because they can book outside the slot on the weekend. They just have to override. It's
okay.
yeah. I'll follow up on that. And the ends, would the NSWAC ever come to see the patient on the weekend?
No.
Okay. Now, internal medicine, I know they have some slots where they want to do their consults for antibiotics. I don't know if you want to build those slots in Cerner or just have a generic Monday to Friday for them as well.
I am leaning towards generic, but I would make it 7 days a week because they are aiming for 7 day a week coverage. What do you guys think? Or do you think the like CAD pump one should be more specific, Carrie and Shannon?
Well, for internal medicine, for that, all intents and purposes for us, I mean, they're only Monday to Thursday.
right now.
Does that change? Is that changing?
Well, that's the hope. That's what they're working on. Yeah. And there has been some scattered weekend coverage. Would we book, one of those follow-up appointments right now? No, we wouldn't, but
We would not
Could
book
they?
anything, scheduling
Yeah.
like something, unless we had an issue with somebody. They would need to be seen,
yeah.
but if that would that even go to ER? I can't imagine.
Okay.
I don't know.
So just leave it Monday to Friday?
Yeah, I think that's what they want.
Okay.
Okay, and that would be 07:30 to 14:30. So the slot ending at 14:30 means that the appointment is over by 14:30. Is that correct?
It's over by 1500.
By 1500. Okay, so then we need to have all your slots go to 1500 and then
Yes,
nothing
yes.
on the weekends. Okay. So I'm going to send the slide deck to you, and your homework is to figure out your visual slot design. So your basically your complex slot design. I'm going to move on to appointment instructions and automated appointment reminders. These are two different things, but you might end up having them say the same thing. Appointment instructions are in Cerner. They are configurable at the appointment level, so you could have different instructions for different appointments, but you might want to make them all exactly the same for your clinic. Totally up to you. The instructions pop up when the clerk is confirming the booking. So ideally, the clerk has the patient on the phone when they are confirming the booking, and they can tell the patient verbally anything that's in the appointment prep. It'll pop up on the screen. This appointment preparation screen is also easily printable, and they can send it to a primary care provider's office or mail it to the patient or whatever your process is. So you can see an example here of instructions that's really simple. Please bring your care card, something to eat or drink, versus a more complex one from Lionsgate to tell people where to pay, park, and where to check in. So I'm going to give this to you for homework. You need to decide what appointment instructions you want for each of your appointments, and I'd recommend as few different ones as possible to keep your maintenance low. We don't want to have to change these all the time. And then the next thing is automated appointment reminders. These are not in Cerner necessarily. There's a question in Cerner when the patient is being booked that asks them, do you want a reminder? And then if they say yes, then the clerk will have to input the patient's email or phone number, depending on how they want to be reminded. And we're going to need information from you about what you want in your appointment reminder. Go ahead, Kim.
Okay, so again, I don't want to speak for you guys, but when I was thinking about this, do we have to opt into this? I guess is my question.
No, you can opt out. Yeah, you don't have to.
Just because we change the appointment so often, these people will get 50 million texts.
Yeah.
Yeah, I don't know. What do you guys think?
That's a very good point.
Is there a way to say that these reminders will only go out the day before?
Yes.
When it starts?
Yeah,
That
so
was
you have
gonna
an
be my
option.
exact-
You can pick 1 day before, 3 days
Yeah.
before, 5 days before, 7 days before, or 14, 3 days before. So if you think there would be a value, if you choose the 1 day before option, then we can opt you in. You don't have to opt in for all your appointment types. You can do only some.
Yeah,
You can think about it if you want.
Yeah, I have been thinking about it, and that was exactly what I was going to say too, Shannon. Like, I would not, for oncology too, I would not do anything except 1 day before, because
But
there's
even
so
then,
much
you're gonna have
change.
to be there. People are gonna have to really look at it.
Yeah,
Because if someone changes it, they're gonna actually have to look at the reminder to see the time. Maybe we'll talk.
Yeah.
to them about
well,
that.
we'll prompt
We'll
them to
figure-
say there is a possibility. We're going to give you your card, but there's a possibility that you will get a text reminder. Or no, is it text? Yes, we can do text with
So
this one.
you can choose. So I'll go through this quickly because you don't sound sold on it yet, so I won't spend too much time. But They can choose a phone call. If they choose a phone call, they'll get a human being voice reading most of the message, but then anything that we tell them you want specific for your appointment or for your clinic, it'll be kind of a computer generated voice telling them that part. So they will receive a call and have to listen to this. I think the COVID message is gone or greatly reduced. But it will tell them if it's an in-person appointment, it'll tell them it's an in-person appointment, please arrive 15 minutes early, and then whatever your appointment preps are. So this is something you'd have to tell us, same thing. What do you want to tell them about their appointment? Check in at the front desk, bring something to eat, whatever you want there. And you can use the same appointment preps for all your appointments, or just like that previous slide I showed you, we can have some specific things for some of your appointments. So for a long infusion, you might want to tell them to bring something to eat, but for wound care, maybe you don't. They can also choose email. If they choose email, they get an email that looks something like this. The thing in the red box is the configuration that I need from you. So this is an example from one of our other clinics. And also if they choose text message, there's not enough space for any special instructions. They're only going to get this very basic reminder that is where you're supposed to go and when, and it's either in person or the doctor will call you. No check-in or anything like that. And the patient you can decide you don't want to do SMS messages. You could opt out. You could also opt out of phone messages. You could say we only do email. It's totally up to you.
Is there any way in Cerner to manually send out one of those reminders? Like, is there a button that we can click that says send email reminder?
No, because this is a function outside of Cerner. All we do in Cerner is document whether the patient wants a reminder and what their contact information is. And then that gets extracted and sent to this standalone system and they launch the reminders. So I'm going to leave that with you as well. And this is, we're not quite done yet. So all of the wonderful information you've already given me about your default appointment lengths, we're down to the last, how many things here? Down to the last 8 items where I still need you to tell me the default appointment length. Unfortunately, you can only have one default appointment length per appointment. And infusion antibiotic is shared with all antibiotics except vancomycin loading. So it's literally every other antibiotic, and also for any of your CAD pump patients. So I need you to pick one time. You told me that you wanted something, I think you told me you wanted something like 2 hours, but typically people choose 30 minutes for this. So I wanted to bring it back to you to make sure, because the default time is what's gonna load for the clerk when they go to book this appointment. They can override it, but the default will be, yeah, whatever you tell me. So I wanted to bring this one back.
So, sorry, you said the default for other sites has been 30 minutes, 30? Okay.
Yeah.
And this would be something that the nurse was triaging, realizing that they're getting something that has to be given over an hour, say.
So this the appointment type length can be changed at the time of booking, and then actually in your nurse screening and triage process, you could also tell the clerk how long to book for on that paper printout.
Yeah, yeah.
But we do need a default in the system that's going to represent the majority of your appointments. And I wasn't sure that, I think you told me, I think it was 2 hours. I wasn't sure that was going to represent the majority of your appointments.
No, I think we went with like the longest possible.
Oh, the long one.
Really,
yeah.
It probably is 30 minutes then, Carrie, do you agree? And then we would have to make it longer if they had more than one or that something longer. Okay.
Yes, I would say most of them are half an hour.
Most are half an hour.
But it's just the days and when they're also getting their pick dressing changed.
Yeah.
But
But
then
we would have to make another appointment for the pick dressing change. Is that correct?
and then seeing internal medicine that day. So there's all separate appointments for the same patient.
Correct.
That's up to you. If you want to encompass all of those clinical activities in the antibiotic appointment, you
I think that
can.
would
So
actually be better. For
But
scheduling.
if you want to grab additional data nuggets, then you can book additional appointments if you're doing additional things. So definitely if someone was getting 2 different infusions in a day, you would book 2 different appointments. So wherever you have somebody getting chemo and red cells in the same day, you're going to book 2 appointments. Even if you book them over top of each other, you want to keep track of those 2 things. But if someone's in for their CAD pump change and you're going to do some other stuff as well, it's up to your operation if you want to book those additional appointments for dressing changes and things like that. Because the CAD pump power plan has in it the pick dressing orders. These other ones, I'm just going to send them back to you. You didn't give me a default time for cyclophos. I wanted to remind you that infusion generic applies to just so many appointments. You told me 180 minutes, so I just want to make sure that you're good with that. Rabies injection prophylaxis, we need one. Pre-post procedure care, you told me you wanted 15 pre and 4 hours post. I'm sorry, it's one appointment type. You have to pick one. I can't do a different one for pre and post. Discontinued chemotherapy infusers new. We haven't talked about it before, so I need a default time for that. Assuming you go live with pick insertion, what default time do you want for that?
So the chemo infuser, I can tell you right now, we'll book it as 30 minutes.
30,
It won't take
okay.
30 minutes, but we'll book that as 30 minutes. Pick insertion, I think we will say 4 hours.
Okay.
That seems long, but
You think that's
I
too
don't know.
long?
I think that sounds like a really long time. I don't even know how you could ever have a bed for 4 hours anywhere. But I would have to have one of the nurses here do it and see how long it takes them. 'Cause we don't
Exactly.
even
So
know that.
we can change it, right? Yeah.
You
You can change it.
Shorter.
Yeah.
It's very
So
easy to change. We just need something to plunk in for now.
Honestly, Kat, I don't think this rabies is gonna fly. I think
Okay.
I think you're gonna have to pull it out of our bill
Okay.
probably. I will follow up one more time, but I think it's gonna come out of our bill and go into emerges. Unfortunately, we just can't seem to get around that.
Okay.
Privileges and credentials.
Yeah, I get it.
Yeah, thoracentesis.
You told me you wanted 30 pre and 30 post for the doctor, but do you want to book
Say
2
90
separate
minutes.
appointments?
I would say
For
an
IM?
hour and a half.
I would say
Yeah.
90 minutes for sure.
Okay.
Just
Okay,
to
so we'll
capture
just-
it.
Okay, 90 minutes. And then for VAC and PICO, as it stands right now, it's the same appointment type, so I just need you to pick one.
Well, if you're carrying, it all takes you 25 minutes.
Okay,
More
That
like
depends on-
12.
Yeah. Including documentation and cleanup.
That's probably right, 60 and
Oops.
30.
It's gonna
You
take
have
her
to
so
pick
much
one.
longer now.
Is it-
Can it
do
be
you want?
like 45?
Yep.
That's so
Can you put-
awkward, Shannon.
Sorry.
It is
Okay.
awkward.
Okay, well then, I don't know.
I'm
I
sending
guess
this
default 30,
with you.
default 30.
You don't have to
Default
tell me now.
and then we can make it
Okay.
longer for a specific patient if we need to.
Yeah, okay.
Okay, and then Hep B immune globulin, I've heard 2 different things from you. One is that it's rarely done. Now you told me it's never done. If you ever want to be able to do it, I have to configure it.
I'm not doing it.
It's just an intramuscular injection.
I guess
30 minutes.
30 minutes then.
Okay.
Well, I don't
and
know,
this-
is there any
Yeah.
post, is there any
No.
post,
I don't understand
Nothing?
why we would ever have to do that.
What about like blood infusions? Are those transfusions like?
That we
captured in
have,
there?
Shannon, you missed, we have a list of 70 things. This is just the 10
Oh.
things where I didn't
That were
have
outstanding.
the time to review yet.
Sorry.
We're
You came
at
in at a
time
good
now. Mark and I were way too optimistic about the length of time on the session. We're at our hour. Does anyone have to go immediately or can we keep going for, well, it'll be about another 15 minutes.
I'm okay, are you okay?
Thank you for your time. Sorry about that. This is another topic we have to get your decision on, not today, but we do have to explain it. Requisitions in the future state are going to print out of Cerner whenever a provider orders a diagnostic test or a laboratory test and some other things as well. And they're going to generate at ACU when a provider places an order against an ACU encounter. And that's going to happen a couple of different times. Again, I like to lay out whenever I expect a rec to maybe generate an ACU in order to try to answer the question, how should we configure your requisitions to generate? And your most common requisitions are going to be, the third one down here, outpatient laboratory requisition. If internal medicine writes lab orders in clinic on clinic day, it's going to generate a lab requisition. And the other most common one is this one that I've highlighted in red here, the group and screen requisition in the CBC. Any provider who writes blood orders, there is a group and screen order and a CBC order in the blood order power plan. And if they write those orders against the ACU encounter, which they are going to, it's going to generate lab requisitions for those as well. So even though the doctor isn't in the clinic, they're in their private office, the requisitions are still going to generate at ACU. And so what do I mean by generate at ACU? It means the system's going to spool it. And then the question we have to answer is, what are we going to do with that spooled requisition? Option number one is to have it auto print in your clinic. So literally, piece of paper spits out. And this function we call print to PDF. So that means it also will generate a PDF and then make it available in Cerner for anyone to see and print anytime they want. So the patient will start to have a history of all the requisitions that have ever been spooled for them. The second option is a function we call requisition manager. This is a function that we built originally for BC Cancer Go Live because in a typical visit to an oncology, like to a, let's say a med-onc's office, the med-onc then sits down and fires in a bunch of orders and 10 requisitions will generate. 3 different medical imaging, 3 different lab, a Holter, whatever. And so we needed a way for that clerk who's sitting there at that med-onc's office to see all the requisitions that just generated. And then that clerk then takes care of making sure those requisitions go to the right place. Do they go to the patient? Do they go to some other department? I think it's an overkill solution for an ACU of your size. So we'll show it to you, but I don't think we're going to recommend it. And then lastly is print to PDF only, which means only digital spooling, no notification. The requisition just silently spools into the patient's chart. And then when you need it, you can go and print it. And this is the option that most of our medical daycares use because almost all their orders are of this type where it's the provider ordering from their private office. Go ahead, Kim.
Well, my question is, why is it coming to ambulatory instead of the lab?
So because of the way this, because of Cerner's always going to generate the requisition against the encounter where the order was written. It kind of has to. So if we want those requisitions to go to the lab, one of the options would be to have them auto print and then they just get scooped up off your printer and sent to the lab. So that's an option too. And maybe we should talk to the lab about that.
Like we're not drawing the group and screen.
No,
right?
no, exactly.
Yeah.
Which is why most medical daycares don't want auto print because they don't want
Exactly.
anything to do with most of the requisitions that get generated. What I wanted to ask you about though is how often is internal medicine writing orders in clinic on clinic day that are going to generate a rec? So lab orders, cardiology, anything like that.
All the paracentesis that require albumin, that's getting written in clinic. So that one I can understand. But that doesn't require a group and screen, like that doesn't require lab work.
No.
And then again, kind of in conjunction with these IM follow-up appointments, they'll order labs or labs will have been ordered for the day before, right? Those are the two I can think of off the top of my head. What am I missing, you guys?
Yeah, I don't think it's very much at all, but what I want to make sure we're careful about is if we choose print to PDF only, there's no prompt that the doctor's ordered anything. You know, there's no notification, it's silent. So in a clinic where a doctor's entering orders and expecting a nurse or someone in clinic to do something about it that day, print to PDF only can be a little dangerous because there's no pushing to anybody. So I want to make sure that's not part of your current workflow. But if your current workflow is, if IM writes orders for labs, then the patient's expected to go to the lab. How do we know to tell the patient to go to the lab? Who does that? Do we need a requisition to prompt us to do that?
Usually the doctors say it to us, like, oh, this person needs some blood work, and then they'll tell us that.
Yeah, there are doctors who, like, not just internal medicine though, like who will send us lab recs and we are not lab recs, I'm sorry, like a blood transfusion PPO, and we won't know whether or not they've given them a lab rec. And often they don't.
So that's another.
But I think they should, so.
They should, especially for their first transfusion. We do have some clinics where on checkout every time the ACU says to the patient, do you have your rec for your next group and screen? And then if the patient says, what? Then they go into Cerner and print the rec out of the print to PDF solution and give it to the patient and say, your next group and screen is in 3 weeks.
So we have some patients who have like blood transfusions monthly, dependent on blood work that they get done monthly. And then the provider will just send us that PPO. And so we'll manage it. And that's how we know. So in Cerner, if they order that, do we know that they've ordered that? Like, how do we know that they've ordered that on that patient?
So 2 parts. They are going to order a red blood cell transfusion in Cerner that's conditional on their hemoglobin. And then the patient will go to the lab, the blood orders will be in Cerner. The provider needs to tell the patient to go to the lab. That's their responsibility. They can hand them a paper rec from the clinic. The providers can also print these recs in their clinics. They're just not going to auto print in their clinic. They're going to have to go in, find them and print them, but we can teach them to do that. And then if the hemoglobin reaches the threshold, then you'll go ahead and do the transfusion. The orders will already be there. Does that answer your question?
But ambulatory care will be triggered that there has been blood ordered for a patient.
Yeah, you're going to see the provider's orders in your request list.
So it doesn't matter if we know whether or not they've had, if we see this rec, like that's not, we don't need that to trigger us because we'll know about the hemoglobin. Okay.
That's right. You'll have an order for a transfusion. You don't need to see a lab rec to know if a patient's been sent to you for transfusion.
Okay, well, I think that makes sense then, like not having it auto print, because then we'll have to phone the patient anyway to see when they're going to go and talk to them about getting a blood transfusion. And then we would say, like, do you have the rec? And then we can print it off for them and take it to the lab, that kind of thing. But usually, a lot of times they've had the rec. I don't really think, I think having it just going into their file is fine for us.
I wonder, Mark, let's follow up with the lab, because at a site like this where there's literally only one lab, I wonder if we should just be forwarding paper recs to the lab for everybody, and then the patients are just told to show up. We don't, yeah, I don't always like to do this, because for patients who are quite sick and are coming for weekly INRs and a whole bunch of other blood work, it's sometimes hard for the lab to tell if today is the day they're supposed to do the group and screen. It's always better if the patient shows up with the rec. So we'll have to work out some nuances there. But I think we're going to recommend for now just print to PDF only. If this is a problem in clinic, because the IM's ordering things where they want a rec and you all keep having to go in Cerner to fish them out, we can turn on your auto print for you. I'll think about that and we'll get back to you. But I think requisition manager, this is an image of print to PDF, by the way, so I should have shown you the pictures. Is a list in Cerner of every lab requisition that's been generated. And all you have to do to open it is just click the hyperlink, then you can print it. And this is an image of Requisition Manager. This is what the BC Cancer clerks deal with on a daily basis. So you can see this is a multi-patient list. So what a clerk will do at BC Cancer is they'll sit there and configure it to say, I'm working in MedOnc ACU today at BC Cancer. Show me every rec that's generated by a doctor working in MedOnc ACU. And then they get this list and they have to mark them as actioned. And yeah, it's quite robust. So overkill.
Don't show that to Becky.
Okay, last little bits are just some easy config. Message Center Pools is your virtual Cerner group email box. You're each going to have your own Message Center account, but I want to discourage you from using your individual accounts and instead try to use the pool. And the pool is where other Cerner users can send you messages. And so we recommend for a medical daycare, you'll get one pool that's called ACU admin, which is clerical, and sometimes the PCC will watch that pool as well. Go ahead.
Outside of our email?
This is outside of your email. This is Cerner email, and you have to have a Message Center account. I'm sorry about that. And then we'll also make a pool called ACU Clinical, which we would expect all nurses to be in, as well as the PCC. And I hope that you will eventually find it useful, but if you don't, I mean, yeah, we can shut the pools off, but you will have a personal Message Center account, even if we shut the pools off, even if we unconfigure them. I personally use Message Center to send messages to medical daycare pools as an informaticist, and I also message doctors through Message Center a lot if I find problems with their orders. The reason why Message Center is nice is because it contains hyperlinks to the patient's chart. So if I go into the chart and I find a problem, I click a button that says communicate. I send a message to the provider. When they get that message, it says that Kat Martinek has sent you a message about this patient. They click one button and it opens the chart. So it keeps all of this confidential information contained in the system. And also you can save messages to the chart. So if a provider continually doesn't answer you and you need to start documenting, you can send them a message in Message Center and click Save to Chart. And you can send the message that says, we need new orders. We've been asking you for 6 months. Anytime you want to put those in would be great, and save it to the chart. And that usually gets them to do better. For minor procedures, I don't think you need any Message Center pools. I think if you're going to communicate with surgeons in Message Center, they should use your ACU pools. Have I got that right? They should know.
I think we should keep it all in one pool. Yes.
Okay, so we'll just call it ACU. Clinic flags we talked about briefly, Cam, but I'll describe them again. It's an option. A clinic flag, I'm showing you in the lower corner here how they're applied. If you put a flag on a patient, it's applied at the patient level. So that means that it doesn't matter what encounter you're using or what encounter anyone else is using. It is adding a flag to a patient, and you own that flag. And if a patient with your flag is admitted to an inpatient area or an emergency department or I think UPCC anyway, or a deceased encounter, you will get a notification that one of your patients has been admitted. This is really helpful for medical daycares with patients who are constantly getting admitted so that you know they're not going to show up for their appointment, or that other things need to be changed. And you can add the flag to whatever patients you want and not other patients. Totally your choice. You have to add the flag and remove it manually. There's no automation whatsoever. So this is a clerical task. Typically, you tell the clerks every blood, IVIG, infusion, and antibiotic patient needs a flag. None of the other patients do. Or you can tell them, whatever criteria you want for them to put the flag on and take it off. So we will configure you a flag. We'll call it qGH ambulatory care unit. The ways you get the notification, you have two choices. The first choice is a message in your message center pool. This is what most people pick. You would get a message every day. We usually will do it, say at 0700 every day, we'll tell you who got admitted in the last day. So when you come in first thing in the morning, you have a list of who got admitted yesterday. The other way we can tell you is with a printout. So same thing, print out on your printer at 0700. Go ahead, Shannon.
Will it only tell us who got admitted in that past day, or will it tell us who's admitted and who's also new admits?
Only the new ones. Yeah.
So we won't know if someone gets discharged.
Yeah, well, we know if they've been discharged. That's a good question.
No, you'll have to go into Cerner and look them up. So do you know, you can get back to me later, but you have to choose one or both. If you want a message in the message center or print out, that's all you have to tell me. And for minor procedures, I don't know if you want clinic flag for those patients as well, or if they're not usually your admitted folks.
I think the no-show rate for that is pretty low, isn't it? For lumps and bumps.
Oh, no-show rate for lumps and bumps is pretty low.
Yeah,
Okay.
that's probably not necessary.
Okay, so just your ACU, and you have to tell me how you want your notifications, and then that'll be done. And we'll also do that for chemo, but we'll talk about that at another meeting.
I think the message pool, that's my vote, but
Yeah, an email would be fine.
Yeah.
If we'll have to,
Okay.
we're gonna log into this
we're logging in.
right away.
One
so.
last thing. One less
Okay.
thing.
So we're just going to go over some quick system defaults now about your printers, fax machines, and labels. This is the last bit of slides. So in Cerner, we call documents is the big term to mean everything to do with the patient's demographics, all of your forms, labels, face sheets, all that stuff, they're all documents. And when the clerk registers the patient for their appointment that day, so when they're checking them in, a default set of documents will print. Typically for a medical daycare, we default one face sheet and one armband. Everybody who's getting a medication needs to be banded. So that's why we default an armband label. And the face sheet you can pitch after the appointment. Typically you'll put it in a chartlet. So in the new world, we hope to transition you away from permanent charts for almost all of your patients. And then everybody will get a chartlet, which is just a manila folder, doesn't have their names stuck on the outside or anything like that. They get a temporary chartlet for just the day. So the face sheet is useful to just clip to the front of the chartlet or tuck it inside or whatever. And then at the end of the day, if you made new paper for the patient, you're going to send it to HIM. So if you've got transfusion records or signed consents or something, you're going to put it in the send to HIM bin, and then the face sheet you can chuck. And then the manila folder goes back in the stack of blank manila folders. Am I painting a picture of a chartless future wonderland? I hope so.
Why do we still need a face sheet?
Just to identify whose chartlet is whose, it's totally up to you. We can disable the face sheet. This is just our recommendation for starters, especially right after go live. You're still going to have your big paper charts. And so it's helpful to have a Cerner face sheet. But then after that, we can get rid of it if you don't want it. And then clinicians can also pop into PowerChart and generate documents as well. So if the face sheet goes missing or the armband gets destroyed, nurses can also go into PowerChart and generate documents. And we just need to set a default for what documents a nurse would want to make. And we're just going to set it the same as when the patient registers. Nurses can always change that. You can pop in and say, oh no, actually I'd like to print some specimen labels, or I need 5 armbands or whatever. But those are the defaults we'll start you with. Just confirming these are your phone and fax numbers for both ACU and minor procedures. Okay, and that's it. So I'm going to make a couple changes. I'm going to send you the slide deck, and I'm always available to meet with you if you need more help or consultation about your slot design. I'm not going to give you any deadlines yet. because I'm not entirely sure when those are, but it's getting important to configure your appointment book. So I'll put it to you that way. And I'm always available to come and meet with you in person. Also, if that's easier than doing this online, I can pop by and we can map it out together. Anything else I can help you with today before we end? Okay, awesome. So I'll send this out on by the end of the day or on Tuesday. Thank you.
Thank you.
Thank you.
Bye.
Thanks, everybody.
Thank you.